I'm going to take you straight to a case that I saw recently, and I want to ask you a couple of questions as we move along. So this is a 75-year-old lady who's hypertensive and dyslipidemic. She developed epigastric chest pain with radiation to the chest and left arm and came with this EKG. And as you notice, there are some ST elevation in the precordial leads. The patient was loaded with aspirin, clopidogrel, and heparin. Preparation for urgent cardiac cath were underway. However, the chest pain resolved in the emergency department within a few minutes, and the cardiac cath was deferred. And this is the EKG when the pain resolved, and you see there is some resolution of the ST segment elevation. And over the next day, this is a very poor rendering of the EKG. There is some total resolution of the STs, but there is some T-wave inversion. The troponin was elevated. So dynamic ST elevation, troponin elevation. Patient is now feeling fine. As per the criteria of the ESC, and there are some recent one in 2015, the rise and fall in cardiac troponin and the dynamic ST changes would put this patient at high risk, and therefore invasive strategy is very much indicated. So I'm sure no one of you here would not do a cardiac cath. I think all of us would agree that this patient would need a cardiac cath, not urgent anymore because she quieted down on medical therapy or perhaps spontaneously. So we took her the next day for a cardiac cath. This is the right coronary artery, which was fine. This is the left coronary artery, so I want your attention to the left coronary artery. There is sort of what we felt was a 40% lesion in the prox LED prior to a diagonal, and this is the way it showed here. We were very surprised. Normally when you have positive troponins, typical history, and especially if you have dynamic ST changes, you would normally see something to do. Here we felt that there was really no indication for an angioplasty unless we feel differently from yeah, I mean, we felt, and I'm showing you just two views, but from multiple views, we did not feel that this was hemodynamically significant. So she remained stable over 48 hours with no recurrence of chest pain. She was discharged on a beta blocker on clopidogrel, which was started in the emergency department as I indicated, on aspirin, rosuvastatin, Micardis, and Nexium. She went home and she returned. This was in July of 2015. In September, which was 7 weeks later exactly, she came to my clinic. Not as a scheduled appointment, but just she came because she said, I'm doing fine, but I have some new brief episodes of mild chest pain with exertion. Okay, so anybody would tell her we had a cath just 7 weeks ago and it was fine, or would anybody do something different by a show of hand? Cath again? Stress test? Okay, maybe a little bit more would do a stress test. We did this stress test, stress thallium, maybe, large anteroseptal reversible defect. Okay, so how many of you would think that that lesion that I showed you 7 weeks earlier was significant? Versus how many would you think that there was progression of disease? So, significant lesion to begin with. Okay. Okay, a good number of you. The ladies? Okay, how about that lesion that I showed you has now progressed? Okay. And again, who would think that this lesion was significant? Okay, so still a bit more would think that that lesion was significant. So we recath the patient, and this is the lesion up there. Yeah, well, that pointer is not, I can see the pointer here, but not there. But anyway, so you see this lesion right at the bifurcation there. It looks much worse, and you see it here, and it looks much worse. So obviously, this is a perfect example of progression of disease and residual risk. So this lesion was probably not significant, it just progressed, and it became significant. And this is the problem. And of course, we stented it. It was a quick, direct stenting, even though it was a bifurcation, but I was not worried about plaque shifting. The plaque was very soft to begin with. So that brings to mind the pathophysiology of coronary atherothrombosis. As you know, the clinical manifestation of ACS is either the rupture or the erosion of a vulnerable plaque. Rupture in 75% of the cases, erosion in 25% of the cases. Vulnerable plaques typically have a thin fibrous cap and a large lipid core and many inflammatory cells. Remember that most MIs arise from non-stenotic plaque, and some of them arise from stenotic plaque, but the vast majority will arise from plaques that are less than 50%, just like the one I showed you. And patients with ACS have multiple active plaques at the same time, and this has been well demonstrated. So the bottom line, when we treat a patient such as the one I showed you, there is the clinical manifestation of this acute phase with a ruptured plaque, which is only the tip of the iceberg. But on the subclinical end, we have the presence of multiple coronary plaques, persistent hyperactive platelets, and vascular inflammation. And at the center of all of this is the platelet. The platelet, we all know, plays an important role in thrombosis. Once there is the right insult, such as a ruptured plaque, the platelet goes into the continuum of adhesion, activation, and then aggregation. But other than the thrombosis, which we're well accustomed to in terms of the role of the platelet, there is the role of inflammatory mediation. Laboratory studies have shown that activated platelets produce inflammatory molecules that can contribute to all stages of atherosclerosis. You see here a lot of inflammatory modules, such as the platelet factor 4, platelet-derived growth factor, RANTES, CD40 ligand, and so on and so forth. And in fact, the platelets have the ability to modulate atherothrombosis via interaction with other vascular cells. The platelets, for example, bind to neutrophils. The platelets promote the transformation of monocytes to macrophages to foam cells. The platelets can recruit endothelium progenitor cells. So the platelets do a lot in terms of promoting thrombosis, chemotaxis, inflammation, oxidative stress, cell differentiation, and so on and so forth. So that's why there was a lot of research that have focused on how to inhibit the platelets. The platelet mediators, thromboxane A2 and ADP, have been demonstrated to play a dominant role in the initiation and propagation of coronary thrombosis. And over time, there has been a lot of medications that has been studied. Ticlopidine was an old friend that didn't last long because of its effect on neutropenia. Clopidogrel is still a good friend. We've learned about dual antiplatelet therapy in the early 2000s after the CURE trial from Salim Yusuf, and then prasugrel and ticagrelor came on board. So to look at the different properties between these drugs, I want to remind you that clopidogrel's mechanism of action works as a prodrug. It is an ADP receptor antagonist. However, it needs to be oxidized by the hepatic cytochrome P450 to generate the active metabolite. And however, there is the cytochrome P450 polymorphisms in response to, and the response to clopidogrel, which is not always uniform. That's because carriers of a reduced function CYP2C19 allele have significantly lower levels of the active metabolite of clopidogrel. therefore leading to diminished platelet inhibition. And that's why the response to platelets, the response of the platelet inhibition to clopidogrel is very heterogeneous, as you see on the slide. It is not uniform. So probably about 20 to 30% of people we put on clopidogrel are not going to be well responder. We call them poor responders to clopidogrel. So this is something we've always known. So then came other medications such as ticagrelor. I know ticagrelor, we use it here in Saudi Arabia, correct? And you use ACTWhen, prasugrel, or not yet? Not yet. Okay. But I'm going to talk to you about both because I'm sure prasugrel is on its way too. But these two medications are used practically all over the world. Ticagrelor is a new chemical class. It's a CPTP. It's also an inhibition. It inhibits P2Y12 by directly binding to it. It is not a prodrug, so therefore it does not need to be converted in the liver, so it works directly. The good thing about it is that it acts quickly. So you see here that clopidogrel in yellow, in about half an hour from giving the loading dose, will give you 50% inhibition of platelet activation, while clopidogrel remains, inhibition of platelet activation remains very low. And as you continue, the clopidogrel gets up to about 50% inhibition at about 4 hours after loading with 600 milligrams. We're talking probably 3 to 4 hours. And both medications will give you a continuous and sustained effect, but ticagrelor have a higher degree of platelet inhibition. The two were compared in the PLATO study, 18,600 patients with unstable angina or acute coronary syndrome. The majority were acute coronary syndrome. And the ticagrelor was compared against BRILINTA. The primary efficacy endpoint was shown to be favorably reduced by ticagrelor, 9.8% versus 11.7%, and this was statistically significant. However, also in terms of secondary efficacy endpoint, myocardial infarction was significantly reduced within a year's time with ticagrelor, and also cardiovascular death alone made a difference and was significantly reduced with ticagrelor compared to clopidogrel at 1 year. How about primary safety endpoint? Do we pay a price in terms of bleeding risk? And the answer is no. Overall primary safety endpoint was equivalent at 1 year with the two medication, clopidogrel and ticagrelor. So that's why, and more specifically, 7,500 patients of STEMI patients from the PLATO study also responded well, favorably to ticagrelor compared to clopidogrel. And this is a good indication for ticagrelor patients with STEMI. Now, one side effect I want to bring up to your attention, which I'm sure you're familiar with, those of you who use it. But first of all, let me remind you that ticagrelor, part of the chemical structure of ticagrelor resembles adenosine. And that's why you're going to have some of the adenosine-like effects. Some effects are favorable, such as the vasodilator effect and the endothelial progenitor cell migration effect, but some is not favorable, such as the increase in dyspnea. It is felt that dyspnea as a side effect of ticagrelor occurs in post-market analysis in probably about 15 to 20% of the people. Okay? How do we deal with it? The features of dyspnea related to ticagrelor are different than the classic features of COPD or pulmonary edema or pulmonary congestion. The features of TICA-related dyspnea is sudden and unexpected air hunger It varies widely. The episodes can last for minutes. It's not typical of the other features of COPD, of pulmonary congestion. So the way to do with it is be patient. After excluding other causes of dyspnea, help the patient walk through it for 3 or 4 days, meaning help the patient accept it for a few days, and most of those episodes would resolve and the patient will be fine with it. However, drug discontinuation should only be considered when dyspnea is persistent and cannot be tolerated by the patient. Now let's turn to prasugrel. Prasugrel also needs to be metabolized in the liver, like clopidogrel. However, it has a greater antiplatelet effect than clopidogrel because it is metabolized more efficiently. Also here you see that there is a more quick action compared to clopidogrel in terms of platelet inhibition. Again, like ticagrelor, within half an hour, you get up to speed with it with about 50% platelet inhibition. There is much less platelet inhibition variation or variability with prasugrel compared to clopidogrel, so this is beneficial. And in a randomized comparison of the Triton-TIMI 38, randomizing prasugrel to clopidogrel, there was benefit in terms of cardiovascular death, MI, and stroke, but this was at the expense of an increased TIMI major bleeds. However, when patients who are over 75 and less than 60 kilograms were excluded, then we were left with ACS patients who are under 75, over 60 kilograms without prior TIA and stroke, who showed benefit and without an increase in TIMI major bleeds. So these are the type of people that are truly candidate for prasugrel. And STEMI is particularly a good population to also administer the drug to. Prasugrel, therefore, the precaution is do not use it in people who are over 75 or less than 60 kilos. And one contraindication is a history of TIA or stroke. Now back to our residual risk question. This patient progressed, and the residual risk is well known after an ACS because regardless of how ACS present, post-discharge mortality remains high. 1 in 5 patients with ACS will have died within 5 years of their index event. PEGASUS is one trial with ticagrelor that basically looked at beyond 1 year of treatment after ACS, and when compared to placebo, ticagrelor 90 milligrams BID or 60 milligrams BID was actually favorable. But of course, it was at the risk of increased bleeding. However, if we look at net clinical benefit in terms of lowering the endpoints without causing irreversible harm, such as cardiovascular death, stroke, or intracranial hemorrhage, then ticagrelor long-term was beneficial. It is still new. The study is still new. It has not made it through the guidelines, but this sort of brings up the question of residual risk. Now, when we talk about how to use those antiplatelet agents, ticagrelor is superior to clopidogrel. And glycoprotein 2B3A inhibitors, in fact, as per the guidelines, are not really to be used. It is not recommended to administer glycoprotein 2B3A inhibitors in patients in whom coronary anatomy is not known. In the American guidelines, the AHA guidelines, ticagrelor in preference to clopidogrel for patients treated with an early invasive strategy. So both for our patient, both from the ESC guidelines and from the AHA-ACC guidelines, our patient who came in with acute coronary syndrome and progressed with the disease, this patient was switched from clopidogrel to ticagrelor simply because we should have started with a stronger medication than clopidogrel to begin with, just based on the guidelines. And that's what we did. We switched the patient to TICA. So with this, I'm going to stop and thank you very much.